Good morning again. What I've tried to do is sort of incorporate what's happened in the last year and try to really highlight what I think is new and interesting and will impact your clinical practice. In keeping with the gastric theme, I feel like this is an appetizer, sort of small plates for the feast that you're going to get through the next few days with the rest of this conference. I have two objectives. The second one we'll definitely get to, which is to talk about the things that have come out that will impact your labor management techniques, your choices for cesarean delivery, for post-op pain management. But I feel like that can't rightly be done without talking about maternal and fetal well-being. If our patients aren't safe, then the things that we do with spinals and epidurals and all the rest don't really matter in the end. So I'll begin with a section on maternal health and what threatens that and what we can do to try to help that. We'll talk some about the fetus and then anesthetic management, but the reality is they're all intertwined, and they're intertwined within the talk as well. So let's start with maternal mortality. In the late 1990s, the WHO gathered together a really international group, and they targeted a 75% reduction in maternal mortality by 2015. By 2010, maybe a 45% reduction. Well, now we're in 2015. So how are we doing? Depends what country you're in. And if you're in the United States, compared to the rest of the Western world, not very good. We're at about 16 maternal deaths per 100,000 live births. If you look at Canada, we're twice as much. And if you look at where we were in 1987, we were at 7. By 2009, we were at almost 18. Now, a little bit is what we call case ascertainment. We're better at picking out those deaths and recording them, but still, not great. So what have we learned? There are tons and tons of series you can look at from the UK, from Canada, and from our country as to what's going on with these deaths, and I'll present a couple of them for our reference. This one is one of the most recent that came out in 2015. It begins by saying what I've already learned in my own life. Being older is definitely not better. If you're greater than 35, significant increase in deaths. Unfortunately, there's also a racial disparity. Non-Hispanic blacks, 40 per 100,000 live births, 40 deaths per 100,000 live births, compared to 12 for Hispanics and 12 for non-Hispanic whites. What we have now in the United States, thanks to people like Dr. Meyer, and you'll hear more about this later, is what the UK and Canada have had for quite some time. Multidisciplinary groups of people, CRNAs, OB anesthesiologists, nurses, and obstetricians get together, and they actually analyze the deaths, and they try to see what we can learn from them. And it's amazing, consistently, what they say. They say that more than half of the deaths are due to inadequate care or substandard care. And when they're pointing the finger, they're not just pointing the finger at the obstetricians, they're pointing the finger at us as well. So what can we do better? Well, it starts at the bedside, and you're going to hear more about these maternal early warning criteria. And we're going to hear more about them in our own institutions as well. Dr. Meyer is going to tell us about them. But basically what the concept is that we know that these young and healthy women look well until they fall off the cliff. And by then, it's often too late. So it turns out that by paying attention to their basic parameters, their hemodynamic, their respiratory parameters, and actually having some bumpers or boundaries, so that when they go outside of those parameters, one of us is called to the bedside to take an extra look. That can make a difference. It doesn't mean that they're all rushed off to the ICU if their heart rate goes below 50. But it makes us look at them and say, why is that happening? Is it because their spinal is on board, or is it because of other reasons? Looking into the causes of maternal death is also helpful, so we can kind of be on the lookout. This is one of many analyses of the causes of death. This one in the United States in 2015. Top 5 for live births. Women who had live births died of embolism, cardiomyopathy and cardiovascular conditions, infections and hypertensive disorders of pregnancy. Those who had stillborn, infection, other comorbidities, hemorrhage, hypertensive disorders, and cardiovascular conditions. So let's spend a few minutes looking into these things. First, cardiovascular disease. Still relatively rare in pregnancy, 0.2 to 4% of the pregnancies, but the rates are increasing. 26% increase in contribution to maternal mortality, 2006 to 2020. And these things tend to happen when we tend to see the patients in the third trimester or the postpartum. And if they do have something like an MI, some of them do die. And the other thing to know about these patients is whereas some of them are the patients you'd think, high cholesterol, diabetes, hypertension, and all of that, they have some very unusual etiologies as well. Coronary dissection, for example, more than 40%. It's not something we're used to thinking about, but something you should know about. Postpartum cardiomyopathy varies a lot by the particular ethnicity and country of origin of the patients, but also increasing, prevalence increasing. And again, during the times when we see the patients, third trimester, postpartum. These are the patients who just don't look right when they come in or after delivery. They're short of breath, they've been sleeping on pillows, they don't have other known etiologies or diagnoses. There has been some association noted in the literature with preeclampsia. Not clear. One of the newest analyses, retrospective analyses, looked and said, actually, it may be chronic hypertension that's really driving this, not so much preeclampsia. More for us to know about. Hemorrhage. No matter what kind of practice that you practice in, we can't transfer out hemorrhage, even if we're in a low-risk population. There are many studies that talk about what's going on with hemorrhage. This is just one of them, a very large retrospective review, more than 8 million hospitalizations, hospital admissions, and it showed a doubling of hemorrhage. And some of the expected risk factors were present: advanced maternal age, multiple gestation, cervical laceration, preeclampsia, and of course cesarean delivery. But here's the kicker. Changes in these risk factors only accounted for less than 6% of all of these postpartum hemorrhage increases. And what this means is that women are not walking around with a sign saying, I'm the one who's going to bleed. Now there is some newer data to say that there may be some genetic predispositions to hemorrhage, that people who have had hemorrhage in a prior pregnancy are more likely to hemorrhage again. So each year we get a little closer to having an idea of who's going to hemorrhage, but we kind of need to be prepared for anyone. This publication from the European Society of Anesthesiology began to summarize for us how we could be prepared. This is what it had to say about obstetric hemorrhage. You're going to hear a lot more about these kinds of things from Dr. Butwick and others in this conference. One, fibrinogen, a good thing to follow, both in terms of trying to predict hemorrhage and ongoing hemorrhage. The one problem with it is that it takes a long time to get the lab value back. As a result, point of care testing, things like thromboelastography and thromboelastometry or ROTEM are more and more being validated in pregnant patients. One thing to know about fibrinogen is that it's much higher in the pregnant patient, and therefore we should have a lower threshold to know that our patient is actually active bleeding. And in fact, there are some studies that show if the patient starts out with a lower fibrinogen, even something like 2.9, that patient may be at risk for postpartum hemorrhage. If you are as unlucky, and she is unlucky, to have a patient with malplacentation, accreta, percreta, increta, everyone would agree that these are serious cases. These patients need major multidisciplinary conversations. In our tertiary care center, even though we're used to all kinds of crazy things, these patients get placed in our main operating rooms, still cared for by our teams, with multiple surgical teams involved, GU, vascular surgery, and such, with interventional radiology right there. And now about resuscitation, again, something that you'll hear more about. Think all factors. not only FFP and red blood cells, but platelets and fibrinogen replacement, either in the form of cryo or concentration. Cell salvage has been used more and more in the obstetric postpartum hemorrhage setting with good results. 2 trials I want to call to your attention. One is the age-old question, what transfusion ratios should we be using? We've moved from the battlefield to trauma literature. This is the most recent publication that I've seen, multi-center, looking at trauma patients, and basically what it's asking is the red cell to FFP ratio. Should it be 1:1 or 1:2, excuse me. And basically, no difference in mortality, 24 hours or 30 days in this trauma patient population, but less death from exsanguination when you had the higher ratio with FFP, and not more complications, which are things that people have worried about. Is this applicable to our patients? Certainly something for us to think about. Tranexamic acid, certainly used in liver transplantation. This study, hopefully by the person standing here next year, will be able to tell you the answer next year. This study is in our patients. It's international. Its target is 20,000 patients for enrollment, and it's specifically looking at if you use tranexamic acid early in postpartum hemorrhage, will it influence death? Will it influence the need for hysterectomy? And really, are there thrombotic and other complications that you have to worry about? Now, I put this in to talk about simulation and checklists for a moment, because whether it's hemorrhage or other critical events, we're all about checklists now. This was one of Atul Gawande's early studies, and basically looked at if you took teams in simulation crisis situations and you gave them simple checklists, some of which they were familiar with, some of which they weren't, and gave them 5 minutes to review those checklists. Did it make a difference? The answer was yes. On the y-axis is failure of adherence to critical steps. The big bar was without checklists, the little bar with checklists. They did better, and they liked the checklists. They wanted more of them. And all of us are going to be seeing more of these checklists. So what's new in hypertension in pregnancy? Well, why do we worry so much about it? So we know that 1 in maternal deaths are attributable to stroke from some retrospective views of UK data that we have. And some data that we looked at showed that women with hypertensive disorders of pregnancy, like preeclampsia, they're 5 times more likely to have stroke, and they do poorly when they do. Not only that, but you've heard that these patients have future risk for cerebrovascular and cardiac disease. But a study in Circulation in 2013, not only just if they have severe preeclampsia or chronic hypertension with severe preeclampsia, but even gestational hypertension, they too, even systolic hypertension during pregnancy, they have an increased risk of MI later, even cardiac death later. So what's new? Certainly, it's all about early recognition of disease. So much so that what ACOG basically said is that it takes too long sometimes to say, does this patient have proteinuria or not? So if she's hypertensive, if she meets criteria, and she has some of those severe features, end organ dysfunction, increase in her creatinine, headache, she is preeclamptic without documenting proteinuria. Mild preeclampsia, out of the lexicon, even though it's still used in my institution. It's preeclampsia without severe features. Prophylactic therapy, not much that really works. Aspirin in a very small subset of patients. The treatment of monitored hypertension, there's a lot of debate going on. The American Heart Association says yes, ACOG says no, and everyone agrees that you really need to monitor these patients postpartum, because that's when a lot of bad things happen. So what can we do? Turns out there's no particularly superior antihypertensive agent, just a few that are not particularly in use by us and not recommended for use. Nimodipine, ketanserin, and magnesium, not that it's problematic otherwise, but it shouldn't be our antihypertensive agent. There was a small, sort of cute randomized study that looked at nifedipine oral and labetalol, and they looked at them in a hypertensive emergency. And interestingly, the oral nifedipine did better in terms of getting control of the hypertensive emergency without the overshoot hypotension that we might worry about. And then finally, there's a beautiful description, thanks to Dr. Scavone and her colleagues, of how we use adjunct agents when we have to intubate one of these hypertensive patients, because we should worry about that hemodynamic response to laryngoscopy. And we should use an adjunct to intubation, nitroglycerin, labetalol, remifentanil. There's another dose-finding study that says that the ED95 to use in addition to your induction agent for remifentanil, 1.34 mics per cc. Infection is certainly a problem. In fact, H1N1 accounted for a lot of those 2009 deaths. What about sepsis? A huge retrospective study done by one of our SOAP members. Sepsis is rare, complicated 1 in 3,000 deliveries. Severe sepsis and sepsis-related death, even rarer. But here's the thing. Both the disease processes and the organisms are not rare. Pneumonia, GU infections, uterine infections, E. coli, staph, and strep. So again, these aren't the women coming in with some pseudomonas or something else. These are the women that we're seeing who come in who are young and healthy with pyelo and then are in the ICU intubated with ARDS. So you at the bedside looking at them saying, they don't look well. They look like they're getting sick, and really acting on it is crucial. There are some conditions which predispose women to sepsis. If you have congestive heart failure, you're 135 times the risk. But overall, all of these things, even including premature rupture and retained products, less than 10% of the risk. Most of the women are just like you and me. When we think of anesthesia, morbidity, and mortality, you've heard a lot about this morning. And absolutely, we're not losing women because we can't put in the ET tube. And failed intubation is basically talking about couldn't complete the rapid sequence induction on the first attempt. So this survey, again, 1 in 224, about 10 times the surgical population, the general surgical population. But like you've already heard, good news, LMA rescue being used a lot. The one woman in this particular survey who needed an emergent surgical airway, she did well. There were 4 who aspirated, but they did well. And of the 3 neonatal deaths, they happened to be in the successful general anesthetic category. Again, the SCORE project, you know this data. I'm going to use this data to look at the 4 things in the most frequent complications and to say, what does the literature tell us that we can do in order to help those complications? So first, respiratory arrest. Well, we give Neuraxial opioids a lot, something that people who give them in the general population worry about respiratory depression. So I thought this was an important start. Our colleagues at Duke looked retrospectively on 5,000 of their patients, and their patients were obese. 17% of them had a BMI greater than 40. And specifically, they let them have the Neuraxial opioids, both spinal and epidural, whichever one was appropriate, not both. Then they let them have as much Percocet as they wanted and non-steroidals. And they looked to see, did any of them need to be resuscitated by the rapid response team or the use of naloxone? Fortunately, the answer was no. Now, this wasn't looking at subtle desaturations. We're actually trying to do some work that's looking at sort of that next phase of nuance. But this was encouraging. At least our basic bread and butter post-op is not killing our women. Where did the high Neuraxial blocks come from? Well, this has been true from the case report literature for quite some time. The condition most likely to lead to this is when you dose up an epidural for a cesarean delivery, you don't get an adequate block, and then you pull out the epidural and do a spinal after that, particularly a full dose spinal. So a cautionary tale to all of us. There are other options. Replace the epidural, a very low dose spinal CSE, using the epidural to bring up the level if you need more. How about these unrecognized spinal catheters? Well, for those of you who use test dose, I show you this particular study because probably the most interesting thing to come out of it was that no one ever waits the 3 minutes to see whether the intrathecal dose is intrathecal. So, and I myself have been totally fooled when I've watched the resident, everything looks perfect, and then before I know it, there is a level up to here. So again, something to think about. I show this picture out of great respect, and I found this study very useful. What it basically showed us that in our morbidly obese patients who have the highest risk of neuraxial complications, either the paramedian sagittal oblique ultrasound view or the transverse median view can be used to estimate the depth to the epidural space. The one note of caution is many of us compress the tissue when we're trying to get a good view. You need to come back off that tissue in order to get a realistic estimate of depth. But this can be very helpful and avoid all of that time, wasted time spent with all of those false losses along the way. Ultrasound in general, a meta-analysis, you saw the actual forest plot or the data from this already. This was looking at both lumbar punctures and epidural catheterizations. Decreased relative risk of failed procedures, traumatic procedures as secondary outcomes and insertion attempts and needle redirections. All good, but I'll say a couple of things. One, anyone who does this regularly, and it's usually a relatively small number of centers who have done the vast majority of this literature, will say in order to do it in difficult patients, you have to do it all the time. The problem, unless you're a new learner, it's not particularly helpful in the majority of patients who are relatively easy to put epidurals in. So you really have to train yourself to do it all the time if it's going to be very useful to you in those difficult situations. Post-dural puncture headache. We've heard a lot about that today, so I'll mention just two things briefly. If we're looking for the magic bullet, once we make the hole, a medicine that we can give them to make it all better, we don't really have one. Nothing is great to avoid the headache. I'm not talking about treating, but avoiding the headache. IV cosentropin in this review, they couldn't even do a meta-analysis. The studies were too weak and too heterogeneous. Maybe the best, but more study needed. And this study you've already heard about in detail, this newer study about the prophylactic blood patches. I came to the same conclusion. Maybe on the highest risk patient or someone where you had a terribly difficult time finding their epidural space, you might think about doing this, but the study was not the cleanest study and certainly not convincing that this is the thing of our future. When we turn our attention to the fetus, fetuses don't like a very warm environment in the mother or a very cold environment when they're born. Maternal antibiotics and neonatal sepsis workup is what happens when the mother has a fever. And there is also an association with neonatal encephalopathy and maternal fever. So it's no joke. And babies, particularly preterm babies, is an increased risk of death when they're cold. So how can we impact a baby's temperature? Well, you probably already know that when we put in a labor epidural, we raise maternal temperature. And there's been a ton of literature. Is this really infection? We think not. So what is it? We don't really know for sure. Well, a recent study looked and said, whatever it is, if we give the women antibiotics, do we decrease the incidence of maternal temperature? Unfortunately, the answer is no. Now, in our hospital, we're on the East Coast, so we're very slow to adopt any of these more touchy-feely things. It's become very popular to do early skin to skin in the operating room. We're very excited that we've discovered this now. So the moment the baby is born from the C-section, she goes over to the warmer, or he gets dried off and quickly comes to the mother. In the meantime, the mother is exposed, the baby's exposed, and everyone gets cold. So it's not shocking that both the mother and baby get cold in this. So this study, these folks figured out that if you actively warm, you put the bear hugger or something like that up there, that everyone gets warm. the mother gets warm, the baby gets warm, and everyone's happy. I please, if anyone in the audience can figure out how to have skin to skin, your blood pressure work, your IV work postpartum, and the bear hugger all in the same space, please come find me afterwards, because I struggle. For any of you who are either the first responders when babies are born routinely or occasionally when the first responders don't come, this is important to know. This is for very premature babies, 22 to 28 weeks. There's always a bit of consternation. More oxygen or less oxygen? What should your target be? You worry with less oxygen that they're going to have all kinds of morbidity and death. With more oxygen, retinopathy of prematurity and bronchopulmonary dysplasia. Big multinational study in the New England Journal. And they were very surprised at what they found. They actually found an increased risk of death when the O2 sat was 85 to 89%. And the clear conclusion from this was aim for a target O2 sat in these very premature babies of 91 to 95%. So in our anesthetics, have we built a better mousetrap? You cannot talk about anesthesia, obstetric anesthesia, without talking about CSE versus epidural. And you'll certainly hear about this later in the conference as well. I'm going to just show you a couple of things. This was a very nice, clean study from 2013 that compared the two, a lot of patients, a private practice institution, only about 3 or 4 individuals doing the cases. So a perfect setup. The primary outcome, pain at the end of the first stage of labor and shortly after delivery, and then some secondary outcomes as well. So what did these folks find? There were in fact lower pain scores at the end of the first stage with the CSE. But here's the thing, on a 0 to 10 scale, 1.4 versus 1.9. We celebrate when we get these scores by any means. So I'm not sure clinically very significant. And in terms of the side effects, more transient fetal bradycardia, self-limited, more side effects, such as itching, self-limited. There were, in fact, more top-ups when you did the epidural, so the anesthesiologist had to work a little harder. Unfortunately, what I think is in some ways the most important outcome, the study was not powered to show, and that was, were the epidurals better, ultimately. This was a more recent meta-analysis that tried to look at whether the epidurals are better with CSEs. Unfortunately, what they were able to actually show, this is in more than 1,700 women, what they were actually able to show was a reduced risk of unilateral blocks for the CSEs versus the epidurals, a relative risk of about 0.48. There was a fairly high amount of heterogeneity in the studies, meaning the studies were not that good to really put together. The methodology and the designs were fairly different. They were not able to show difference in the rate of catheter replacements, top-ups, or vein cannulations, and they basically said, we need a much larger prospective study to be able to think of showing that. When we think about how we put medication through our epidurals, there's been a lot of work, and you'll hear more as well on this, to show that boluses, whether it's the patient or the machine that puts boluses through the epidural, gets us the best spread. And this isn't surprising, given that we're not admixing the medicine with any fluid. We can't use baricity anyway. We're just putting the medicine through a potential space. So these authors are among the folks who are really the most progressive, and they did a really cool thing. They rigged the machine to be able to not only give intermittent boluses, and these machines that give intermittent boluses, programmed intermittent boluses, are on the market now, you should know. But they also coordinated it with the patient's PCEA button. So the more the patient pushed the PCEA button, the more the machine gave intermittent boluses. And if she backed off, the machine backed off as well. And they wanted to know if this worked well. And they found out it worked great. Analgesic efficacy was great, satisfaction was great. Anesthesiologist top-ups, which was their primary outcome, were many, many fewer. And the other thing which I found interesting was the rates of machine-delivered boluses were greatest when she was fully dilated. And by the way, this was compared to our more usual PCEA with a background continuous infusion. And the outcomes in terms of need for cesarean delivery or fetal outcomes were not different. So what this means is that left to their own devices, when you don't interfere at all, the patients get more medicine, at least in this study, when they're fully dilated, and nothing bad happens about it. So I loved telling my obstetricians about this study. Nitrous oxide is something old that's new. When I talk about nitrous in my travels to Canada and the UK, they laugh at us because this has been there forever. Nonetheless, it has some advantages. It's inexpensive, it's portable, quick on and offset, preserves mobility. Unfortunately, studies haven't really looked at patient satisfaction, which is probably the most important thing. When you look at straight analgesia, the evidence isn't great, but the reality is certainly not as good as epidural. In some studies, not even as good as placebos. Remifentanil, believe it or not, there were tons of studies on remifentanil for labor in the last few years. I chose this one because I thought it was well designed. It's a randomized trial, and it basically looks at both, well, it looks at three things. It looks at efficacy and maternal satisfaction, and also looks at safety. And I'll tell you the punchline. The punchline is, if you're talking about pain relief, the pain relief is less with the remifentanil. If you're talking about satisfaction, the satisfaction was comparable with the remifentanil. But here's one important thing as we think about our serious complications. Anesthesiologists were actually in the rooms of these patients, and there were 27 witnessed apnea events, serious apnea events, while these patients were getting their remifentanil. So something to certainly think about when you're thinking of patient selection for this kind of technique. What about when we're doing cesarean deliveries? What's the right thing to do? I don't know if you've had this experience, but I've had OBs come to me and say, now, this is definitely not a patient you should do a spinal on. Do not drop her pressure because she has a marginal placenta, absent diastolic flow on ultrasound. Definitely not. Well, these folks put this to the test. They did relatively low dose spinals, at least for our institution, 8 milligrams, and they compared it to general anesthesia. And they took a good measure of fetal outcome, umbilical cord base deficit, and they said, did the fetuses do worse? And the answer was no. No difference in base deficit. Very small difference in umbilical cord pHs, but not putting them in a different category, not clinically significant. A very small difference in hypotension, but easily treated. And the GA babies had a higher PaO2, but not a necessary higher PaO2, and required a little bit more resuscitation. Probably a lot of the reason why we're able to do spinals so well is the way we've learned to be able to maintain blood pressure. Again, I chose this study because I think it gives us a nice recipe to use. This took a phenylephrine infusion in the background, starting at about 50 mics in most patients, with whatever rescue boluses would need it, and it compared it to if you just use rescue boluses of phenylephrine. And it said, which needs more physician interventions, in which case do you have more nausea, vomiting, hypotension, all of those kinds of things. Here, more color is bad. So the gray is when you didn't have the phenylephrine infusion, but only the rescue boluses. And what they found is the physician had to intervene a whole lot more when there wasn't that nice infusion in the background. The patients got more hypotension, more nausea and vomiting. These authors just recently, in 2015, took it to the next level, and they said, all right, now we're really spoiled. We want this to be great. And sometimes we get this really nasty bradycardia. What if we have a patient where we're really worried about bradycardia? How about Levofed? Let's try that. So they did a computer-controlled infusion comparing norepi at 5 mics per cc with phenylephrine pretty high, 100 mics per ml. And they looked at the outcomes. And what they found was actually better cardiac output at 5 minutes, but both had very reasonable cardiac output. Similar systolic blood pressure, stroke volumes, and bradycardia wasn't as much of an issue. Not to say that we all have to rush out to use Levophed, but gives us another option, particularly if you have a patient that you're worried about. This study was already referred to. These are in patients that we haven't intervened on yet, but when we do our uterine displacement, when we lie them down, this showed that even before you do a spinal, what we are considering uterine displacement at 15 degrees does nothing. You need at least 30 to 45 degrees tilt, which is sure to send your obstetrician shouting that they can't possibly do the case in that position. But something for you to know if you're having trouble with the hemodynamics. I thought this study was fun in the sense that often when we have very obese patients and have to choose a spinal or a CSE, we'd really rather have the CSE if we could. And these folks put it to the test. Does one take longer? Is one more successful? And the bottom line was no. If anything, the single shot spinal took a little bit longer than the CSE. And that was probably, I'm guessing, because that little introducer doesn't give you much tactile feedback. Whereas if you approach your spinal with the large epidural needle, perhaps you're more likely to eventually be able to get to the spinal space when you put your longer spinal needle through it. I'm going to close with TAP blocks. So many studies about TAP blocks. TAP blocks on top of neuraxial opioids, not a lot of pros. Very short-term benefits at most, but no long-term benefits in terms of pain management. And some high serum concentrations, particularly if the ropivacaine is dosed on a mg per kg basis, and some seizures. Case reports of seizures, and then in another study that was not with neuraxial opioids, but just looking at TAP blocks versus ropivacaine local anesthetic infusions, the study was actually stopped prematurely when one of the patients in the TAP block group had a seizure. Finally, as we look for things, more things in our armamentarium to give our patients if they can't have neuraxial anesthesia and they can't have neuraxial opioids, what about just straight ropivacaine infusions? Is that better than just using opioids? In terms of pain relief or reducing the amount of opioid rescue, in this study, not so much, unfortunately. So in summary, with a deep breath, what have we learned? The key in keeping our patients safe is knowing who's sick at the bedside. And if we can do that, we can have a dramatic impact on both maternal and fetal outcomes. And then we have the opportunity to really work with them and use all of the techniques which we continue to perfect year after year. And fortunately, most of the things that we're doing are working out pretty well. Thank you so much for your time.